to the sixth session of Listen to the Legends, presented by West Bengal Academy of Pediatrics. And today we are very much honored and delighted to have the legends of today, Dr. Nitin Kumar Shah, who will be delivering a talk on blood components, confusion, and the consensus. I think this evening will be very interesting. And on behalf of West Bengal Academy of Pediatrics, I am welcoming you all to just imbibe this academic feast. And I will just hand it over to Dr. Professor Mihir Sharkar to introduce Professor Sukanta Chatterjee, who is the moderator of the session. So over to you, Professor Sharkar.
Thank you, Professor Swapon Kumar Roy, the President of West Bengal Academy of Pediatrics. So today we have a very important topic when we have guru in the one of the pediatric hematology in our all over the country. So for moderating this session, it is my proud privilege to introduce Professor Sukanto Chatterjee sir, who is my teacher. And sir has been the head of the department of the pediatrics for the Medical College Kolkata and the other various institutes at the medical colleges all over the West Bengal. He has been given the inspiration to the many of the pediatricians who are doing the lot of good activities all throughout the country and the West Bengal. Sir has been the EB of the West Bengal Academy of from the West Bengal, the Central IIP, and this is the third time in a row. And sir has a special work and the still going on at this age, continuing going on, and sir dedications to the adolescent health, getting the awareness of among the pediatricians of the adolescent health and the different health related issues of the adolescent age group. So sir, with this I will hand over to you to introduce our esteemed speaker and carry on the session.
Thank you, Dr. Mihir, my beloved student, for the great, I should say, introduction about me. And let me now introduce the giant or the legend, we must say. Everyone is eager to listen to the legend, Dr. Nitin Shah, who is the head of pediatrics of Hinduja Hospital, Mumbai, and also oncologist of Walia Hospital and visiting pediatric oncologist of Apollo Hospital. He was president of Indian Academy of Pediatrics 2006, and he is such a president still now. Whenever Nitin Shah stands somewhere, people stands around him. So he's so popular. There's so many presidents I have seen, but this is something exception. You are really legend, sir. And then he is a fellow of IIP and chairperson of IIP PHO chapter, and then editor of many books like textbook of pediatric hematology, textbook of fetal hematology oncology, and also IIP subspecialty series books. Delivered more than 200 guest lectures and published more than 100 articles in various journals and books. This is only one slide of it. If we read the entire CV, then you will be deprived of listening the scientific topic today. So I'll restrict myself here, and I'll request Dr. Nitin Shah to take the stage and present the presentation.
Thank you, Dr. Sukanto, for that nice introduction. Thank you, Dr. Swapan Ray, President of the IIP West Bengal, and all the other office bearers and professors and teachers who are tuned in. It's a great honor for me to be speaking in this Legend series, and I will like to then share some of my thoughts about the blood components and the blood transfusion. What are the confusion and what are the consensus? So with that, let me share my screen. Yes, you are able to see my screen, right?
Yeah.
All right. So when I was the president in the year 2006, I'm sure some of you might still have this book of the IIP national guidelines, where 17 guidelines were made on the various topics, including the public health and the subject very dear to me, that is the hematology and oncology. So these are those 14, 15 guidelines, and there were 2 more added later. This book was then sent to all the IIP members that time through the support from UNICEF. And in that, the most important guideline, I would say, was the guideline on blood component. Now, that was in 2006, and we are in 2024, but still in 18 years, really nothing much has changed as far as the basic concept of using blood and blood drug is concerned. So, why blood components? Why not whole blood? And I think in periphery, a lot of people still use whole blood, and I must say that that's a complete waste of a very, very rare human resource or product, because blood, cannot be made in the laboratory. So it has to be donated by human beings who are healthy. And from one blood, you can actually make so many components to satisfy the need of multiple patients who need them. So, like suppose you want to give platelet, you cannot use whole blood, because the platelets in the whole blood will be completely destroyed once the blood is stored at 2 to 8 degree. Because the platelets have to be stored at 20 to 25 degrees. So you cannot give platelets as whole blood. And if you want to really give number of platelets, the number of blood unit you will need, it will lead to a lot of fluid overload. Let's say clotting factor, hemophilia. First of all, again, on storage, factor 8 has half-life of only 8 to 12 hours. Factor 9 is half-life of 12 to 24 hours, and factor 7 is half-life of only 2 to 6 hours. So if you're going to store the blood for even 24 hours, most of this clotting factor will disappear, and you just cannot give whole blood to satisfy the need of prevention of bleeding or arrest of bleeding in a patient who has got a known or unknown clotting factor deficiency. As I said, blood is a rare commodity. So if you can fraction it into various components, the same bottle of unit actually can satisfy multiple patients. And last but not the least, when you use whole blood when it is not indicated, it can lead to volume overload and can push a patient into CCF. Like suppose you have a child with 4 gram hemoglobin who has got tachycardia and just palpable liver which is tender, which means he is in threatening to go into CCF. When you load it with, instead of packed cell whole blood, he will surely go into failure and you will not be able to salvage it. And lastly, there are things like which are unwanted in whole blood. That are like say lymphocyte, and if you can remove the lymphocyte, because lymphocytes have no role to play in a recipient. In fact, the donor lymphocyte can create havoc or hazard in the recipient. We will come to that little later. So if you can remove the lymphocyte, again when you give whole blood, those lymphocytes are not removed, so obviously it will lead to toxicity. So you can see here there are various reasons for which you will want to fractionate the whole blood bottle into various components. So what are the components and what are the functions? So you can see there are more than 6 important components. Of one, the most important is the RBC and the hemoglobin within, which carries the oxygen and carbon dioxide. So very important in the overall respiration and metabolism of a cell. WBC, especially neutrophils, are very important from infection point of view, and lymphocytes are very important from the point of view of controlling viral infections. You have bleeding, which is arrested by platelets and by the various clotting factors. There are 13 clotting factors, of which even if you remove factor 12, the other factors are very important. And then there is albumin in the whole blood, which is very important from the oncotic pressure. In fact, the fluid remains and the blood oncotic pressure remains essentially because of albumin. So if you have low albumin, there is a lot of fluid overload in the body. So by making components and using components instead of whole blood, it has really touched upon the survival of several specialties in pediatric, especially the preterm babies, in NICU, even full-term babies, surgical patients, oncology. I cannot think of treating a leukemic child without having component, thalassemia patient who need only PRBC, and so on and so forth. So we have to fractionate whole blood into various components. Now let's see this case. 3-year-old child has come to your OPD walking with this CBC. Pediatrician has referred to you for this CBC. Hemoglobin is 3 grams, MCV is 45, MCH is 20 picogram, RDW is 26. The platelets are high at 5.5 lakhs. WBC count is 5,600 with 40% poly and 60% lymphocyte. Child is still on bottle feed and gets constipated and is listless and crying and clinging to the mother when he comes to your OPD. Now, what will you give him? Will you give him 15 cc per kg of whole blood? Will you give him 15 cc per kg of packed red blood cell? Or will you give 5 cc per kg of packed red blood cell? Now, as the delegates are not on the Zoom link, they are in the YouTube, so I really cannot get a live answer from there. But the answer is none of the above. This child has come walking to a clinic. He has got chronic iron deficiency as the MCV is very low, RDW is high, and the platelet count is even higher, more than 5.5 lakh. He's on bottle fed, very reason to have iron deficiency. So there is no cutoff in nutrition anemia where you will transfuse the patient. You will transfuse only when the patient is in occult or overt congestive cardiac failure. So you will not give any of these above, and you will actually put him on oral iron and observe him over the next 3 to 4 weeks, and his hemoglobin will jump by 2 to 3 gram, and you will tide over the crisis. So let's talk about the components that we use. Packed blood cell, that is why I put the first case. If the child was on failure, he should have received packed cell and not received whole blood. Platelet, everyone knows about use of platelet. What we don't many times understand is that we sometimes use granulocyte transfusion in a patient with severe sepsis, like say in an onco patient or an immunocompromised, because those granulocytes, though have a very short half-life after they're infused, but they can really help to overcome sepsis where antibiotics have failed. The fresh frozen plasma, everyone knows about fresh frozen plasma, very important to use. And you make from pooled fresh frozen plasma, which means you take 100, 500 fresh frozen plasmas, you mix them and you thaw them, which means you melt them. And when you thaw them at 4 degree, you get a precipitate at the bottom, that's known as cryoprecipitate, which is very rich in albumin, clotting factor like factor 8, intravenous immunoglobulins, so immunoglobulins, anti-D globulins, stem cells, etc. So you can see these are the various factors you can make from one bottle of whole blood, and you can modify them. So you can have a neocyte packed red blood cell, which is just the newest cell. You can freeze some rare blood groups, RBCs, as frozen cells, and can be kept for at minus 20 degrees for even years. You can use WBC filter to remove the lymphocyte. If you can't afford filter, you can wash the cells with saline. It's like poor man's filter. In a patient who is undergoing stem cell transplant, who is immunocompromised, you need to irradiate the blood to kill all the lymphocytes, because that lymphocytes otherwise can lead to problem in that immunocompromised host. And in a transplant setup where the recipient is CMV negative, you will want to use a blood product from a donor who is also CMV negative. So you can see various different components you can use, and you can modify them to suit the need of your patient. So does it mean that whole blood is not required at all? There are very few advantages of whole blood, because as you would say, a whole blood collected very freshly will have all the factors like RBC, platelet, clotting factor, albumin for the first 6 to 8 hours before, because blood can be kept up to 6 hours in the room temperature before it is fractionated into components. But you would never use the so-called fresh whole blood where you have to use whole blood. You always use what is known as 1:1:1 packed red blood cell, FFP, and platelet of the patient's blood group. So you still don't need a whole blood like from a bottle directly, but you use all the three components separately, given one after another, to mimic like what is known as whole blood. The disadvantages are plenty. It has volume overload, it has lymphocyte, it has citrate, it can be very cold in a preterm baby, and so on and so forth. So it is many times whole blood is misused for volume expansion in a bleeding patient, for giving platelet, where as I said, if it is stored whole blood at 2 to 8 degrees even for 24 hours, platelets are just, they are there, but they are not functional. Again, as I said, factor 7, factor 8, factor 9 would disappear in 24 to 48 hours on storage. So again, it is misused for hemophilia A and hemophilia B. It should never be used as a whole blood. So where do you use? Massive transfusion, where the blood loss is so much that all the components are lost and you need to replace all the components. Typically exchange transfusion, like we We have hardly now been doing exchange transfusion with a very effective phototherapy and early detection of a neonatal jaundice. You have double surface, triple surface phototherapy. So in past, exchange was common. Today even RH it may be required, and that's where it's like massive transfusion. So whole blood may be required. Massive bleeding, like in cardiac surgery, thoracic surgery, or in ECMO, the extracorporeal membrane oxygen, where the blood flow through the membrane oxygenator is so high that it actually mimics like a massive bleeding and with needing massive transfusion. So these are the only indication where you use whole blood. But again, here you don't use as a whole blood. You give them 1:1:1 ratio, Paxil, FFP, and platelet. Now, whole blood, because it's a lot of plasma, when you give 10 ml per kg, it raises hemoglobin only by 1 to 1.5 grams. So you can imagine you have a 3-gram child, you want to make it 6 grams, you want to increase 3 grams, you will have to give 20 to 25 cc per kg, and that will be massive volume overload because the patient may not be able to tolerate that type of volume. So, what is massive hemorrhage? Where there is more than one blood volume lost in 24 hours, like all these previous indications that I showed you, or if there is a trauma and there is more than 3 cc per kg per minute of blood loss. You don't even wait for the entire blood volume to be depleted, because for sure over the next few hours there is going to be a lot of bleeding. So here you may have to use a whole blood, which is like giving 1:1:1 ratio of Paxil, FFP, and platelet rather than using as a whole blood. Now, when you have massive hemorrhage, there are other metabolic complications because there is such a rapid turnover of blood, and you are going to use blood product one after another, which are kept at room temperature for platelet, but at 2 to 8 degree for FFP as well as for packed red cell. In fact, FFP is kept at -20 below, but when it is given to you, it has to be thawed in 37 degree water bath and given to you at 2 to 8 degree. So when you give so much of blood product, there will be hypothermia in a small baby. So that is one thing you should be careful about. You have to warm up the blood by a blood warmer, and because you are giving so much of stored blood, there will be problem of citrate toxicity leading to hypocalcemia. There will be release of potassium and acidosis. So these are the things you will have to keep in mind when you have a situation where there is a massive hemorrhage and needing a massive transfusion. So for the commonest reason why you would use blood or blood product is use of packed red blood cell to improve the oxygen carrying capacity. So this is how the packed cells are made and stored in the refrigerator in the blood bank, where they are labeled as the blood group specific and kept in a row one after another. So packed red blood cell is a good way to treat volume replacement where the blood loss is not massive, like in the previous case that I showed you, to improve the oxygen carrying capacity in an anemic child who is going into congestive cardiac failure or is already in congestive cardiac failure. Paxil being packed to 65%, unlike whole blood, which is 40 to 45%, you have removed a lot of plasma. So because the plasma is removed, there is less volume overload, there will be less clotting, there will be less citrate toxicity, and there will be less problem of hypothermia, because for the same rise of hemoglobin, you will use a lesser quantity of Paxil compared to whole blood. And of course, when you store the Paxil, which is stored at 2 to 8 degree in the refrigerator, again the same thing, the platelets become dysfunctional. So never use Paxil for platelets, obviously. And even though little plasma is there in Paxil, that the factor 2, factor 8, factor 9 would have disappeared. And that's the reason why it should never be used in a patient for factor replacement. So it is only for volume replacement, or more importantly for improving the oxygen carrying capacity. So the ideal hematocrit in a patient of a Paxil that the blood bank will give you will be around 65 to 70%. If you are using it for the exchange transfusion, you will keep it a little lower at 50 to 55, because you are going to use double volume exchange, so they may lead to polycythemia. Of course, you have to use ABO identical or compatible blood with a full cross match. And in a baby who is less than 4 months, who may still have maternal natural antibodies, you have to cross match the blood with both the recipient child as well as the mother, and give a blood which is compatible with both the child and the mother. Typically, you can give in a child who is not in failure up to 15 to 20 cc per kg, over 2 to 3 hours. Now remember, there's no hanging of packed cell for 5 hours and 6 hours and 8 hours. In this warm weather, if you keep any blood product hanging for so long, there are very high chances of contamination and infection. So it should get over in 2 to 3 hours. So in a patient who is in failure, you will give smaller Ellicott initially, like 5 ml per kg. Then after wait for 6 to 8 hours, give maybe another 5 to 10 cc per kg. Now the hemoglobin has gone up. The patient is not in failure. The second day or third day, you can give him 15 cc per kg. Now, every 3 ml per kg of packed cell will raise your hemoglobin by 1 gram. So, if you are given, say, 10 to 15 ml per kg of packed cell, it will raise hemoglobin by around 3 to 4 grams or 5 grams at the most. So, you have to calculate based on the patient's hemoglobin, how much you want to raise. You will accordingly give transfusion over 1 or 2 days, not to exceed 15 cc per kg or maximum 20 cc per kg at one go. Now, indications: small baby, anemia of prematurity, if they are symptomatic with low red cell count, which means the marrow is not functioning still, and they have apnea, they have poor feeding or poor weight gain. Otherwise, there is no cutoff of hemoglobin as far as anemia of prematurity is concerned. In a child who is oxygen dependent, either by hood or by nasal cannula or on or a child with cyanosis or an ECMO, you will give little higher hemoglobin at 10, 12, and even 15 gram for a patient with cyanotic heart disease. Now, acute blood loss up to 20% of blood volume, Paxil is good enough as a volume expander. Now, when do you give in a patient who is not bleeding or not a perisurgical? What are the common indications of using Paxil? So, any patient who is undergoing surgery, he is symptomatic. So, tomorrow you have a hernia child with 5 gram hemoglobin. To transfuse him and do surgery is not correct because he is not obstructed. You can wait for the hemoglobin to rise by your hematinic, like if he's iron deficiency, give him iron and wait for a month or two. But if he comes as obstructive hernia, which is emergency, and his hemoglobin is 5 gram and he's symptomatic like breathless, you would want to give him Paxil and raise hemoglobin before surgery. In a chemotherapy, radiotherapy patient, of course, we have to keep the hemoglobin above 7 or 7.5 gram hemoglobin. In a patient with chronic stable congenital acquired anemia, like your thalassemia, like your pure red cell aplasia, like your aplastic anemia, these are the common causes where you would need packed cells. In a patient with emergency surgery and you anticipate blood loss, like a massive orthopedic surgery or a massive cardiac surgery, you would want to give blood intraoperative and perioperative. In a patient where it's not possible to correct the anemia, like suppose you have a child with aplastic anemia, now has come with hernia, there is no way he's going to improve his hemoglobin on his own. Such children you will have to transfuse before surgery. And in presence of infection, because the oxygen demand is high and the cardiac output is a problem in sepsis, you will want to keep a hemoglobin of at least 7 to 8 gram in such patient. But otherwise, there is no cutoff, including in malaria, including in patients with iron deficiency or nutrition anemia. If they are not in occult or overt failure, do not transfuse, treat the basic cause, and the hemoglobin will rise. Now, chronic transfusion-dependent anemias are thalassemias, everyone knows. Others are the bone marrow failure syndrome, like the sideroblastic anemia, aplastic anemia, Fanconi's anemia, Diamond-Blackfan syndrome, or sickle cell. Sometimes you may need to use in sickle cell. Patient with chronic renal failure, because the erythropoietin is not produced, they will need onco patients, etc. All of them would need. Then episodic, like you have a hemolysis in a G6PD patient. Sudden drop in hemoglobin in a G6PD will make him uncompensated. Unlike an iron deficiency, which is chronic, there is enough time for compensation. And the same will be for immune hemolytic anemia, like your Coombs positive hemolytic anemia. They drop the hemoglobin and they will become symptomatic. You tide over the crisis by giving them episodic transfusion as required. But in nutrition anemia, it is rarely required or indicated unless they are in impending or an actual congestive cardiac failure. Packed cells for that by any blood transfusion is actually immunocompromising for the recipient. So do not use this as top up as a better outcome of surgery or in nutrition anemia. In fact, you have to tell your surgeon friend who wants to give packed cell for 8 gram hemoglobin before hernia surgery. You say that if you use that, the chances of wound infection will be more than when you don't transfuse. So you have to stress upon the surgery friends that they don't have to transfuse just because the hemoglobin is 8 grams. All right. What about thalassemia? You always keep pre-transfusion hemoglobin above 9 or 9.5 because that is physiological. Post-transfusion hemoglobin can be raised up to 14 but not beyond, because polycythemia as such is bad. These children already have plasma overload and they have a prothrombotic tendency. So if you keep hemoglobin very high, then they can lead to central venous thrombosis. You transfuse every 3 to 4 weeks by giving them 15 to 20 cc per kg every 3 to 4 weeks. As you know, if you stop producing, let's say marrow fails today, you will drop by 1 gram per week. So in a thalassemia, the marrow is not working as good. So they will drop by 3 to 4 gram in 1 month. So you give every month to raise 3 to 4 gram, which means 15 to 20 cc per kg. So for the students who are listening, there is no need for you to really mug up, understand the physiology behind why you give it. So 15 to 20 cc per kg every 3 to 4 weeks will be enough to keep hemoglobin between 9 to 12, 12 to 9, 9 to 12, 12 to 9, and so on and so forth. You will need, I mean, generally in thalassemia, before the first transfusion, you should do what is known as an extended blood group. So not only ABO, RH, but even minor blood group, because they can develop minor blood group incompatibility over the years because of multiple transfusion, because they are exposed to so many donors. So you do a full grouping at the onset, including minor groups, and you can then give, if suppose the person is B positive, but he is MN blood group negative, then you can search for B positive MN blood group negative donors and give those Paxil, so that not only he has no problem with ABO and RH, but also will not develop an MN related hemolysis. You always do Coombs cross match because of the multiple donors. They can have sensitization to minor blood group, which you can easily make out if you do a Coombs cross match. You should actually use filtered blood. Nowadays, saline washing is given up in most of the centers. You never admit this patient, you bring them to daycare or OPD base, give over 3 to 4 hours and maybe an hour of observation thereafter, and they go home so that they can have least interruption of their life as a student or as whatever they're doing, so that they can have better quality of life. Always record how much was the pre-transfusion hemoglobin. There is no need to do post-transfusion hemoglobin, but if you have done, then record that and record the amount of blood you have given, patient's weight and date of transfusion, and patient's liver, spleen, height and weight in a book, in a tabular form. And if you have, after 15, 16 transfusion, there will be iron overload. So treat that iron overload and do your ferritin every 3 to 6 months and keep a record of ferritin, so that then next time any patient comes, you can just go through that small booklet and you can make out what's happening to the patient. In onco patient, we like to keep hemoglobin above 8 or even about 10 if there is going to be intense chemotherapy where the marrow is going to stop working for some time. If they have infection like febrile neutropenia, severe pneumonia because the oxygenation will be problem, or if they have thrombocytopenia, which can lead to bleeding and very rapid drop in hemoglobin. So all these are indication of giving packed red blood cell. And in a leukemic who has come with very high count, 1 lakh, 2 lakh, 3 lakh WBC, which are all blast, you may do a partial exchange, what is known as leukapheresis. So you put the patient on the machine, remove his blood, remove the WBC, give back his remaining part of the blood, and you keep on doing this cycle every 30 to 45 minutes, and you remove the blast so that you can avoid toxicity of hyperleukocytosis. Okay, that's as far as the Paxil is concerned. I think that's the important blood component that people are going to use. Now let's look at the next case. A 6-year-old child, 16 kg, admitted with high fever, body pains and abdominal pain for 4 days. Sick looking child and looks flush and liver was tender. This is the CBC which he comes with. Hemoglobin of 14 gram. WBC is 2500 with 40% poly and 60% lymphocyte. Platelets are 35,000. NS1, IgG, IgM are sent as come as positive. So diagnosis made as he's got dengue with severe thrombocytopenia. So what will you give? Random donor platelet 2 units, single donor platelet half unit, or random donor platelet plus FFP. Now again, because we don't have the delegates here, I cannot wait for the answer. But again, the answer is none of the above. Platelets are being grossly misused to treat platelet count or number rather than the patient. In a dengue patient, there is no indication of platelet, even with the platelet count as low as 15 and 20,000, unless the patient is bleeding. And how you do know the patient is bleeding? You have given enough fluid, his hematocrit has fallen, but his shock is not improving. So now the shock is not because of hemoconcentration, it's because he's leaking somewhere in the form of blood. Commonest is GI, and they may not show you occult blood or overt blood in the GI. So such patient, and these patients usually also have altered PT and PTD, so they will not only need platelet, but they will also need FFP. So remember, the unindicated platelet transfusion in a dengue patient actually can worsen the outcome with platelet rather than without platelet. So that brings me to the use and misuse of platelet. And you know, platelets are never kept in refrigerator. They are stored outside the refrigerator at 20 to 22 degree. Platelet, when they are allowed to rest, they they clump together, stick to the surface, and they become dysfunctional. So the platelets have to be constantly agitated. So these are the type of platelet agitator where there is a horizontal movement occurring 24/7, so that the platelets do not settle down in the bag which is there in this type of platelet agitators. So platelet contain ABO antigen and HLA class 1 antigen on the surface. Okay, whenever possible, give ABO and RH identical or at least compatible. But remember, even when you give platelets, they may have contamination with some RBC which will have RH. So while platelet don't have RH antigen, but because the contamination of RH, in an RH negative girl child, you should generally not give RH positive platelet. And if you give RH positive platelet, then for every 5 to 6 platelet that you give, you should cover up with 250 to 500 microgram of NTD globulin, which will destroy those RH cell and not allow RH sensitization. Because otherwise, this girl child tomorrow in future, when she become mother and has an RH positive baby, it will lead to massive RH incompatibility issue. So ABO incompatible platelet can lead to hemolytic transfusion, though rare, but more mainly in neonates. Now platelet contain a small number of RBC sets, so in a RH sensitization, you should always cover them up with 250 microgram of NTD globulin if you give RH positive platelet to RH negative recipient. Now platelets are isolated from whole blood at room temperature and kept at 22 to 22 degree outside the refrigerator on a constant platelet agitator to prevent platelet aggregation. And even suppose you don't have your blood bank within your hospital and the patient is going to bring platelet from a nearby hospital, then you are nearby blood bank, then you have to tell the patient, the relative, that they have to keep on everting and inverting the platelet bag every 1 or 2 minutes till the time they reach hospital and is being transfused, so that the platelet aggregation doesn't happen. Shelf life of platelet is just 5 days. So you cannot use it, unlike Paxil, which is a half-life of say now 60 days or 90 days. You cannot use platelet for more than 5 days, and never store them in the fridge. The common mistake, suppose you have a 50 kilo child and you have said, okay, 5 platelets are brought, sister will start the first and she'll keep the remaining 4 in the fridge. Because she used to keep the blood product in the fridge. You have to tell specifically, please do not keep in the refrigerator, keep it on the bedside. Platelets should be transfused quickly. It is just 50 ml of volume, so don't keep on hanging and give for over 1 or 2 hours. It should be quickly given over 20 minutes. So your 5 platelets, they should be all over in maybe next 1.5 hours. Always use plastic tubing. Nowadays we don't use glass syringe, but you know platelets stick to the glass surface and get aggregation. So never use glass surface or glass syringes while you are transfusing platelets. Always give platelet to a platelet set. There is a, like how you have an RBC set, you have a platelet set, so that the macro particles which might have formed because of clumping, they are removed when you use a platelet set. And ideally platelet also have lymphocyte, so you should use a leukocyte filter even to prevent lymphocyte mediated allosensitization. There are two types of platelet: random donor platelet, that is one which is obtained from one bag of blood which you have collected from a donor, and a single donor platelet where you make a patient or a relative or a donor sit on the FRSS machine and you can collect 5 to 7 platelets from the same donor at one sitting. So single donor platelet is not more concentrated, it is more volume from the same donor. So that's a misconception. People think SDP is more concentrated than RDP. No, one RDP is 50 ml, one SDP is 350 ml. So it is more volume, but from the single donor. So you are not exposing the recipient to multiple donors. Like suppose you have 50 kilo child needs 5 platelets. If you take 5 RDP, he will be exposed to 5 different donors. Whereas you have a SDP from a donor of say patient's friend, then he is exposed to only one donor. So that's the advantage of single donor platelet, where you take the donor on the apheresis machine and you use. So what happens? You collect the blood of the patient, goes to the machine separates platelet, remaining blood is given back to the patient. Again, you take one more aliquot of blood, the machine does the same thing, and you keep on doing everything till the time you have obtained the required volume, which is usually 300 to 350 ml. So this is the difference between RDP and SDP. SDP is the same as RDP as far as platelet content per ml is concerned, but because the volume is more and from a single donor there is less exposure, so you give one bag of RDP per 10 kg body weight, that is same as giving 5 to 10 ml per kg of a SDP. So suppose you have a 20 kilo child, you will give 2 bags of RDP, or you will give say 200 ml of SDP. So that's like almost giving one bag of SDP. Now, because of the exposure being reduced, and the donor can donate again within 2 weeks. So what we do in Onco, where you need their, or in a transplant setup where you know they are going to be needing platelets again and again, you ask them to bring 1 or 2 healthy donors, you screen them, and then you in turn you bleed them for platelets. So the patient is exposed to only 1 or 2 donors even when he needs platelet again and again. Now, what are the indication of platelet? Decreased platelet production is the real indication, like in a bone marrow failure, like aplastic anemia, bone marrow infiltration, like leukemia, bone marrow suppression, like drugs or fulminant infection, like sepsis, stem cell transplant, chemoradiotherapy, and so on and so forth. Increased platelet consumption, where the platelets are consumed, like in a necrotizing enterocolitis in a newborn, or a Kasabag-Merritt syndrome in an older baby, or a DIC. When you have DIC, you will want to keep the platelet always above 50,000. It is also required in massive transfusion, as I said, where you use whole blood. So you don't give whole blood, but you keep 1:1:1 ratio of whole blood, I mean packed cell, platelet, and FFP. In patients with immune thrombocytopenia, like your ITP or like your neonatal alloimmune thrombocytopenia, it is rarely required. Why? Because there are autoantibodies or alloantibodies. No matter how many platelets you will give, they'll be destroyed within next 10 to 15 minutes. So suppose in ITP patient, the platelets are 6,000. You give him, say, 10 kilo child, you give him 4 RDP, double than what is required, and you check your platelet after 1 hour, it will be still the 6,000. So really, it's a waste of blood product and platelet, and harmful if you use in condition like ITP. In platelet dysfunction, it is life-saving, but use sparingly, because as you know, when you use platelet more than say 20-30 times, it starts having allo sensitization, and the next time the platelets do not work as well. And this platelet dysfunction patient have lifelong illness if they have congenital platelet dysfunction like Bernard-Sulier or Glanzmann thrombocythemia. So you should use pharmacological agent to arrest bleeding as far as possible rather than giving them platelets. The most common use of platelet is misuse. They are misused in ITP. They are completely contraindicated in hemolytic syndrome or thrombotic thrombocytic purpura. In fact, if you give platelet, they will worsen. Sparingly used in platelet dysfunction, as I said, not indicated in chronic status. Say you have aplastic anemia with platelet of 10,000. He's not bleeding. Don't give him platelet. Don't treat the number, treat the patient. And in dengue, as I said, it is counterproductive if you use unnecessarily. Now, word about platelet prophylaxis. People get worried if I do some procedure, they will be bleeding. So remember, in a non-sick baby, even up to 5,000, don't worry if there is no mucosal bleed. In a sick baby, you can keep that threshold at 20,000, especially if they have associated mucositis, sepsis, or DIC. Now, if you're doing procedures, like you are doing, like you have extreme leukocytosis, you're doing FRSs, then you will like to keep platelet above 40 or above 50,000. Now, for lumbar puncture, I don't keep in a leukemic child any platelet, because I do it myself. I know I will be least traumatic, but otherwise you can keep it at around 10 to 30,000 in a leukemic child. Below 50,000, if it is there for a non-critical site surgery like epidural anesthesia, scopies, biopsies, etc., or below 100,000 if it is there for critical surgery like CNS surgery, ophthalmic surgery, you will want to give platelet and prevent further bleeding. Now, how do you check the effectiveness? So, SDP has 5 to 7 times more platelet than RDP with equally more plasma volume. So, it's not concentrated. That's what I want everyone to understand. Efficacy depends on the platelet factor and recipient factor. So, if the recipient has fever, infection, there will be less platelet rise because they are consumed. Platelet factor, like if they are not stored properly, then platelet rise will be inadequate. And how do you know that there is adequacy of platelet transfusion. Number one, clinically, you are giving it for bleeding. The bleeding should stop. Then platelets are working well. Or you can do platelet recovery. So you do baseline platelet at 1 hour and at 24 hours. Suppose your baseline platelet is 10,000. At 1 hour, it becomes 30,000, which means there's a good rise. And at 24 hours, also it remains as say 25,000, which means this is decreased production. Suppose your 1 hour platelet is 10,000. Baseline is 10,000. At 1 hour is 30,000. But at 24 hours, it becomes again 10,000, which means in the next 24 hours, whatever you give us consumes. So that is consumption coagulopathy. At 1 hour, at baseline is 10,000. At 1 hour also is 10,000, which means it did not go up at all. It is immune cause like ITP or such autoantibody as a cause of thrombocytopenia. So when you give platelet in a patient who is bleeding with low platelet, you don't know the cause of low platelet, then do this exercise of doing platelet count at baseline at 1 hour and 24 hours, and that will tell you whether it decreased production, consumption, or a immune cause of thrombocytopenia. Now, how do you reduce your misuse of platelet? Withdraw antiplatelet drug, aspirin, dispirin, ibuprofen, combiflam, NSAIDs. Treat antiplatelet conditions. So like you have patient with liver disease, you have patient with sepsis, treat that. Raise the hemoglobin to a good level so that even if there's bleeding, patient will not go into shock. Use agents like EACA, DDAVP, etc., which can arrest bleeding, like tranexamic acid. Correct associated coagulation abnormality like PTA, PTD, which is prolonged, to give FFP. Treat associated DIC. Factor 7A is a magic drug which will work in any bleeding, including in patient with platelet dysfunction, provided patient can afford. As far as surgical and intensivist, experienced intensivist and an experienced surgeon will have the least use of platelet compared to the new surgeon or new intensivist. And if all this fails, then only you should consider giving platelet to the patient. Let's move to the next case. 9-year-old child, Wilson's disease, is admitted with fever for 4 days. His hemoglobin is 8 gram. WBC is 4,500 with normal differential count. His platelet count is 80,000. His PT is 19 upon 20 with an INR of 1.8 because he has Wilson disease with liver disorder. His APTT also is prolonged 45/30. So both PT and APTT are prolonged. SGOT is high, SGPT is high, and bilirubin both direct and indirect high, and a very low albumin, telling you that he has probably got into acute or a chronic liver cell failure. Now what will you give? FFP 15 cc per kg once a day, FFP 15 cc per kg twice a day, or you will give FFP as well as cryo to replenish fibrinogen. Now again, I don't have the audience here. The answer is none of the above. This patient with chronic liver disease because of Wilson's is not bleeding. He only has subclinical coagulopathy in the form of raised PT, APTT, and low platelet of 80,000. Unless he bleeds, he is not going to be treated because he is going to be like this for months and years together. If you keep on giving FFP, platelet, etc., it's a complete misuse of the product. So that brings us to the FFP, the third important blood product, and you can see it is always kept at -20 degree and below, sometimes even at -80 degree. So it's like frozen like this, you can see. So what is the basic of FFP? Usually FFP is 250 cc volume stored at below -30 degrees Celsius. At that temperature, the shelf life is 1 year. Now you cannot store FFP in your ward refrigerator because it needs a license, blood bank license. So only blood bank can store it. You can bring from blood bank and use it maybe up to 24 hours, but beyond 24 hours, you either discard it, or if you are not going to use it, immediately replace it. Resend it back to the blood bank. It contains albumin and all the coagulation factor roughly at 1 unit per ml. That is the way you calculate the amount of factor in the FFP. Because FFP is frozen, after collection immediately all the factors are intact in the FFP, unlike the blood which is kept for 24 hours in the blood bank where the factors have disappeared. Once you freeze them, the factors remain viable. The blood bank has to thaw it at 37 degree for 20 minutes and make it liquid and give it to you. You cannot thaw it in your bedside. You can't keep it in a warm water bucket. No, because you don't know how much the temperature. You cannot keep it hanging for 12 hours for it to thaw. No, because everything will disappear. The factor will disappear. So the blood bank has to thaw it under controlled 37 degree and then give you, rather than you doing it. And because it's frozen, the plastic bag may crack. So if there's leakage, don't use it. And once FFP comes to your unit, give it over 30 minutes. No hanging for 2 hours. Give it fast and use it so that you have maximum benefit of all the factors. Now, if the FFP is stored at 4 degree, then it can be kept at for only 4 to 24 hours. And if it is above 4 degree, it has to be discarded. Factors 8 and factor 5 and factor 2 disappear in 24 to 72 hours. The normal dose is 15 cc per kg every 12 to 24 hours. If the patient is in failure, then use smaller dose like 10 cc per kg. Now, first talk about misuse of FFP rather than use. It is often misused as volume expander. No, you use albumin as a source of albumin in the malnourished child or in nephrotic. No, you use albumin or colloids as a clotting factor replacement. Only in a patient who has come for the first time bleeding, you don't know factor 8 or factor 9, you can give FFP to arrest the bleeding. In next 24 hours, you get whether it's factor 8, factor 9, factor 2, whatever it is. And next time you will use the factor concentrate and not FFP. DIC without bleeding, chronic stable DIC doesn't need treatment. Same way, just because the INR is high in a liver disorder, do not use it like the previous patient. In neonates with jaundice, to prevent periventricular hemorrhage, the periventricular hemorrhage is not because of coagulation, it is because of the poor metrics supporting the ventricle, and that is why there is bleeding. So do not use FFP for that, and you can't store FFP in your ward refrigerator beyond 24 hours. So now what are the true indications? Inherited coagulation factor deficiency. For the first time the patient comes, you don't know is whether it's factor 8 or factor 9. You may tide over the crisis by giving 15 cc per kg because it will replace all the missing factor, whichever is there. Next time when the diagnosis is made, you use the factor replacement. Now suppose it's a factor 10 deficiency. Now you don't have factor 10 concentrate available, then you can use FFP in such cases. In liver disorder, a prophylaxis to prevent bleeding before surgery, before procedure like liver biopsy, or in a preterm with hemorrhagic disease of newborn, you give vitamin K, but because it's a preterm, the liver is immature, may not convert the pro factor to the active factor. So you may have to use also FFP to tide over the crisis. So in newborn, along with the vitamin K always, in a sick bleeding baby with hypoxia, shock, sepsis, DIC, etc., you will want to arrest the bleeding. In a DIC with clinical bleeding, you will use FFP along with platelet. In massive hemorrhage, as I said, 1:1:1 ratio, Paxil, FFP, and platelet. And in plasma exchange. So there are very few indications where you do exchange with plasma. Normally you do exchange with saline, as you know, or albumin. But in patient of TTP, thrombotic thrombocytopenic puremia or HUS, you will want to do plasma exchange because plasma has the missing factor, which is the factor which helps to control the TTP. That's known as the ADMTS factor or the Adams factor. All right, we move. 2-year male child, known case of hemophilia B, 10 kg, has come with constant bleed from the gums since last 4 hours. What will you give? Whole blood with 1 cryo, Paxil with 1 cryo, or what will you give? So again, the answer is you have to give him Paxil because he's bleeding and become anemia, and you have to give him factor 9. There is no factor 9 in cryoprecipitate. Is only factor 8, factor 2, fibrinogen, but no factor 9. So for hemophilia B, do not use cryo. And as I said, whole blood does not have factor 8, factor 9, factor 7, etc. because within 24 to 48 hours, all these factors are destroyed. So you will use either FFP or if available factor 9 complex or the prothrombin complex and Paxil if the patient is having massive bleeding with failure. So that brings me to the last component, cryoprecipitate. When a pooled plasma FF, the pooled FFP is thawed at 4 degree and resuspended, you get a volume of 25 to 30 ml at the bottom in the form of white precipitate. That's why it's known as cryoprecipitate. That cryoprecipitate is rich in factor 8, von Willebrand factor, fibrinogen, factor 13, and fibronectin. So it can be used for hemophilia, von Willebrand disease, to replenish fibrinogen. Like in obstetric unit, they use a lot of fibrinogen, and for factor 13 deficiency. But otherwise, for factor 9 deficiency, you never use cryoprecipitate. If you have factor 8, even for factor 8 deficiency, don't use cryo because it's not as good as factor 8 itself. But if patient can't afford factor 8 concentrate, then instead of using FAP, you can use cryo. So indication of fibrinogen deficiency, von disease, hemophilia A, not B, for factor 13 deficiency. You give 1 unit per 10 kg body weight. Generally, 1 unit of cryo has 100 units of factor 8. So you want to raise how much factor? Accordingly, you will use 1 or 2 units of cryoprecipitate for 10 kg body weight. Now, the beauty is for patient with factor 13 deficiency, as the half-life of factor 13 is very high, 20 to 30 days, you need to give cryo only once a month. So bring them to your OPD, prepare the cryoprecipitate, push it over 10 minutes, wait for half an hour, discharge them, and they can come back after one month. Now, what is new in blood banking? Last part of my talk, cytopheresis. We are doing since many years in Hinduja. So what is cytopheresis? It's a machine like this which can do RBC pheresis, leukapheresis, and platelet pheresis. So where do you use RBC pheresis? Severe malaria, like 40%, 50% falciparum malaria. We are not seeing it now very often, but you can do for, it's a life saving. WBC pheresis in a patient who has come with very high blast count, like acute leukemia, 5 lakh blast count, you can do WBC pheresis. Platelet pheresis, already I showed you, single donor platelets are collected by doing this platelet pheresis, and the same machine can be used for plasma pheresis, like in a patient with HUS TTP. The cost is higher, around 15,000 per cycle, but it is worth it because it can save a lot of trouble instead of doing just exchange transfusion. Because in exchange transfusion, there is no control of the volume, whereas here in FRS's machine, there is complete control over the volume and the speed. Second is antibody screen. What is antibody screen? So routine use of antibody screen to detect presence of unusual RBC group antibody. Suppose you are B positive. How do you know you are not MN negative? If you are MN negative, you will have anti-MN antibody. And if you now take blood from an B positive but who is MN positive, you will break that blood after a few days as a form of minor blood group incompatibility. So in a patient who is going to need transfusion again and again, like thalassemic, leukemic, aplastic anemia, you always look for this antibody screen. If the patient has antibody to rare blood group, then you know which blood group donor to use for that patient. So it's important to antibody screen. And we do a panel of 8 antibodies which are commonly seen. And if they are found to be negative, then you are even more sure that there won't be any reaction in the form of incompatibility. Leukodepletion, very important. Why leukodeplete? There are more than 5 into 10⁶ donor lymphocytes, which can lead to febrile transfusion reaction, which are non-hemolytic, allosensitization, so it will lead to poor platelet recovery, and graft rejection if the patient has to undergo stem cell transplant. All viral infection like CMV, HIV, etc. are in the lymphocyte. In a patient who is immunocompromised, it can lead to transfusion-associated graft versus host disease, which is universally fatal to the tune of 95%. If you give lymphocyte-containing blood product to a surgical patient, it will lead to immunomodulation and poor wound healing. And in a patient, rarely it can lead to pulmonary dysfunction. So you can see lymphocytes have really no role to play in transfusion. They better be removed. So how do you remove? So you can see how many platelets are there. RBC, RDP, HDP, everything has significant number of lymphocytes, so they have to be removed before giving. So past we used to do Buffy-coat removal. It is an open method which is very drastic. You should not do it, and it's only 90% effective. So is saline washing, only 90% effective. Frozen cells are 95% effective in removing lymphocyte. Third generation WBC filter is what we use today, and they remove 99.9%, but not 100%. 100% removal is by gamma irradiation. So any patient who is likely to go into transfusion associated graft versus host disease, that is immunocompromised host or a transplant recipient, you should gamma irradiate every blood product before giving to the patient. So WBC filters are third generation. Efficacy is very high, 99.5%, very easy to use. They are fibrin mesh which trap all the lymphocytes, so that almost every lymphocyte is removed. You can have two ways. Previously, we used to use the bedside. So every time the patient admitted, we will give the blood through this WBC filter. But that means you have to use one filter per blood product. Suppose these are a 40-kilo child needing 3 RBCs, you will waste 3 filters. Whereas now what we do is bedside at collections. What is that collection? When you are collecting the blood from a donor, it is passing through the WBC filter. So the entire blood which is collected now is lymphocyte free. Now from that you make Paxil, FFP, platelet. All three products can be given now without a bedside filter. So cost of one filter is divided over 3 or 4 products. And for pediatric patient, that one Paxil can be divided into 3 aliquots of 100 ml each. The small child may need only 100 ml. So imagine how much is the cost reduction instead of using a bedside filter. The next is irradiation. So a 4-year-old leukemic child develop anemia while on chemotherapy, given Paxil 15 cc per kg over 4 hours, deteriorated after a few days, develop fever, diarrhea, skin rash, jaundice, and mucocutaneous lesions like this. And what has happened is the child had developed transfusion-associated graft-versus-host disease. Mortality is 90%. So use blood products which are irradiated, especially in an immunocompromised host or from a first degree relative donor, or in a transplant setting, it is must to give only irradiated blood product. And you can do gamma irradiation by using the same gamma irradiator. Most of the blood bank which are good have a gamma irradiator in the blood bank, and they will give you within no time. All right, net testing. We are worried about infection, HBsAg, HIV, HCV. If you do ELISA testing versus nucleic acid testing, there's a vast difference. You can see here. By ELISA testing, HIV window period is 20 days. By net testing, it is 5 days. For HCV, it drops from 58 days to 5 days. And for HBV, from 53 to 35 days. So this is the advantage of doing net testing, and good blood bank now will give you blood which is not ELISA tested, but net nucleic acid tested for HIV, HCV, and HBV. And lastly, autologous transfusion in pediatric, you can use it for someone who's about 10 years or more than 20 kilo. Somehow autologous transfusion is not catching up in our country, but you can actually use it in a bigger child which is undergoing a planned surgery. So instead of exposing him to a donor blood product, you can give his own blood by having autologous transfusion. In past, we used to collect one blood. After 1 week, give that one blood and collect 2 blood, and all that is not done now. It is perioperative hemodilution. So you collect one or 2 units of blood and give him saline. So you hemodilute it. His hemoglobin will drop from 14 to say 9. He can tolerate that in anesthesia. There will be blood loss, but of 9 gram blood instead of 13 gram. And that blood loss is now given by giving him back his Paxils. So this is how you actually use autologous transfusion. I will end my story. This is a lucky boy, who had come at 3 years of age with hemoglobin of 3 grams, MCV of 56, suggestive of iron deficiency. He was treated with 1 unit of Paxil and he became okay. Everyone was happy. He went back home, and after 3 years, he came back with loss of weight, fever, diarrhea. And this is what Lucky is now, emaciated. And what has happened is a transfusion associated HIV. Fortunately, now we don't get patients of transfusion associated HIV because blood products have become extremely safe after very strict guideline. But I'm not sure whether interiors of country still there might be some unscrupulous blood bank which may not be able to or purposefully avoid testing like that, and there can be a problem. So remember, in past this was a menace. So all I'm saying is that the bottle of blood is meant for the life to begin. Let not any mishap, including death, happen with this. So you need blood audit, blood audit, blood audit, and blood audit. Strict indications of giving blood product, because one, not to waste them, and two, not to do harm. So we have been taught as physicians that first prime is do not harm. Then if you can benefit the patient. So do not harm when blood products are given unnecessarily. And the only way you cannot harm is by having knowledgeable physicians, knowledgeable pediatricians who know when not to use blood product rather than to know when to use blood product. Well, I thank you very much again for giving me this wonderful opportunity to share some of my thoughts, and I hope it will change practice of some of you who are into blood practices and using blood products in your day-to-day life. Thank you.
Thank you, Dr. Nitin Shah, for this excellent talk, and which is a learning for all of us still today, because everything we read and then forget, and then like say delivery or say cesarean section or say blood transfusion all get mixed up, and then finally we still say that, well, we need a fresh blood transfusion. So these are what is fresh and what we should do. That's the myth, and that is really cleared. Now,
So there is nothing like fresh blood. Or we have to
right.
store blood as component and use the way you want, including whole blood, which is not fresh, but it is 1:1 ratio of Paxil plus FFP and platelets.
Now, let us go through the different questions that has been
Yes, please.
put in the chat box.
Yes, please.
Now, there is one question like erythropoietin in prophylaxis of treatment of anemia of prematurity.
So that is given up now. Very few people use prophylaxis because you start at this point. It takes 6 to 8 weeks for it to start acting, and by then the baby will be either out or would be having a poor mishap. So no one uses it. But if you are using it, remember you have to give also good iron, because erythropoietin depletes whatever little iron is available in the baby's body. So you have to give iron, maybe even IV iron when you are using erythropoietin.
So what will be transfusion of choice in severe anemia in a child with severe acute malnutrition?
So in a patient with severe acute malnutrition, if the hemoglobin is less than 4 gram and the patient has got tender hepatomegaly, which means he's likely to be going into failure. Or if he has severe infection, a UTI or fever, you will want to keep hemoglobin then above 7 gram. And in such case, you would give him Paxil. If he's in failure, start with 5 cc per kg body weight every 12 hours. And then after 24 hours, make it 10 to 15 cc per kg. Raise hemoglobin to 9 or 10, and that's where you will end.
Well, then the next question is, as you have said that for surgeons, it's better not to transfuse if they want to give a Paxil transfusion. That will increase the infection.
Yeah, we
So,
routinely give.
why infection is increased?
Yeah, no, so we routinely give what do you call pre-operative fitness for any hemoglobin which is above 7 to 7.5 gram in a child, provided there is no anticipated blood loss like an orthopedic surgery or a CBT surgery. In that case also, they will keep standby blood and use it as required. So there is nothing like why they develop it, because the donor lymphocytes will go and attack the recipient immune system and will lead to increased chance of infection and wound dehiscence. So it is proven beyond doubt that blood transfusion during surgery actually increases surgical infections.
Right. So in acute severe malnutrition iron deficiency, as per CBC and peripheral blood hemoglobin 7 gram, no impending CCF, how shall we proceed?
No need to give transfusion. Treat the SAM with nutritional support and add iron. So iron now when you give is only 3 mg per kg of elemental iron, not 6. The IAP PHO chapter has brought out its guideline, which is already published in Indian Pediatrics long back, that 3 mg per kg is sufficient, even giving twice or thrice a week rather than daily. That will bring down the side effect drastically, and it will be as effective as giving daily 6 mg per kg, but very less side effect.
Well, the next question from Dr. Jalil Ahmed. How will you manage isolated thrombocytopenia, not ITP?
Correct. So if you have to find out what the cause of thrombocytopenia is. So normally we do what is known as immature platelet fraction. If it is very high, it suggests immune. That's like ITP. In a newborn, it will be like alloimmune thrombocytopenia. Alloimmune thrombocytopenia, the antibodies are transplacental maternal antibodies which disappear after 4 months. They carry a high chance of intracranial hemorrhage. So they should be given the same platelet antigen negative platelet transfusion from a donor. If that is not possible, take the mother's platelet, irradiate it, and give it. But in anyone above 4 months, that's not the cause, is ITP, and ITP is managed more for mucosal bleed rather than platelet count. If your IPF is low, that means it is a problem of decreased production. You need to then find out, is it like infection, is it like viral infection, malaria, etc., dengue, etc., or is it some chronic disorder like bone marrow failure or bone marrow infiltrate, and a bone marrow will be required to come to conclusion. So that in nutshell is how we will proceed for or a thrombocytopenia patient. Lastly, remember, you can have pseudo thrombocytopenia, which means, like suppose you have a patient with Bernard-Schiller syndrome. The platelets are very large in size, so they are not counted by your machine. So your platelet count on machine will be 10,000. When you make a smear, it is 30, 40,000 because there are large platelets. So again, be careful when you interpret platelet from a machine vis-a-vis what do you expect from that patient.
Thank you. So next question is, in an RH incompatible newborn, in what ratio we shall use O negative packed RBC with AB plasma?
No, so normally you don't do it. The blood bank has to reconstitute the whole blood in blood bank by mixing compatible plasma, platelet, and PRBC in the same unit and give it to you. So the
Okay.
reconstitution not done bedside, it's done by the blood bank. But in an older child where you're transfusing, you can give one after another, one after another. So that's not exchange, that is transfusion. But for exchange, you need to exchange alicate by alicate. So the blood bank needs to do it for you.
So in case of chronic ITP presenting with menorrhagia, hemoglobin 5.2 gram
Correct.
and platelet 10,000, what
Correct.
would be the approach to the
So
patient?
if that adolescent girl is not in failure, which means she needs iron because she has lost so much blood, she needs tranexamic acid to arrest the bleeding in the form of metrorrhagia. She needs a gynec reference to give her progesterone preparation for the next few cycles. And if all that fails, of course, she will need something to treat for the ITP. So short course of steroids for 4-5 days of high dose steroid 4 mg per kg, or a pulse methylprednisolone for 1 or 2 days. If all that fails, if patient can afford IVIG, and if this is recurrent, like you have treated now, but again after 2 months, again the same issue, or there's poor compliance, then you can consider treating this chronic ITP with something more than steroid and IVIG. And that's in the form of giving them either the thrombomimetic agent like L-Thrombopag or Romiprostim, or giving rituximab. And if all thing fails, then only splenectomy.
Okay, thank you. Now, what will be the lower limit of hemoglobin for blood transfusion in iron deficiency or megaloblastic anemia?
Zero.
Or is it only clinical?
Only clinical, overt or occult failure. 2 gram hemoglobin coming walking, I would give him iron, B12 folate, send him home, call him after 2 weeks, check hemoglobin would have risen by 1 or 2 grams, then he has tided over the crisis.
Now, another question that is usually circulating in the house physicians, is Lasix necessary in the middle of RBC or whole blood transfusion?
Absolutely no. There is no role of Lasix, no role of hydrocod in a patient routinely while giving transfusion. If the patient is very severe anemic and impending failure, give less Alicot, 5 cc per kg. Do not use Lasix. If he's in failure, then he will need Lasix for the failure. That's a different thing, but not because he's being transfused. So no role of, and of course, never use steroid. Efcorlin is not magic drug that you give it to transfusion, there'll be no anaphylaxis. Impossible. Steroids work after 8 to 10 hours. So do not use. But if you have leukemic child suspected and you give him Efcorlin or Visolin or Dexa, and it can lead to temporary remission. So please do not use indicated blood product or steroids in a patient with unknown anemia or unknown thrombocytopenia. It could be a leukemia which will be masked by your haphazard treatment.
So another question is,
again same thing, Sukanto, no evil while giving transfusion. Don't anticipate any reaction. If a reaction happens, then you will use evil, but don't use it prophylactically.
Right. So in doing a blood group of a baby, is cord blood good for that?
Yeah, of course you can use cord blood. There's no problem. So you collect cord blood for TSH, for blood group, for G6PD, and if you want to do further tests, then you can go ahead and do further tests. Like bilirubin, even a patient has got some RH incompatibility and things like that.
So role of autologous blood transfusion.
I already said that in a child about 20
Yes.
kilo, you can use it. Very few people use it because blood is so easily available. And now blood products are extremely safe, especially if they're net tested and filtered. That's why it's going into disvogue, but it is possible to use it.
Is it necessary to warm blood before transfusion?
So in a small newborn babies, yes, it is necessary, but using a blood warmer, or in a massive transfusion, it's necessary. But a 1 or 2 Paxil or 1 or 2 platelets or 1 or 2 FFP, because the baby is big and the volume given is so small, it will be immediately warmed up by the body itself. So there is no need.
So another question is, severe acute malnutrition child with dengue in shock, requiring blood transfusion.
Why would he need blood transfusion unless his shock is not improved, but his hematocrit is improved? That means he's bleeding. So whether malnutrition or no malnutrition, the indication of platelet in a dengue patient is when the patient's shock is not improving, but the hematocrit has started falling. That means you are giving enough fluid and in fact the hematocrit is fallen more than what you suspect, that means he's bleeding. And such case you will also do PT-PDT, that also is prolonged. That is the usual scenario, and such children will need platelet and or FFP, generally both.
So if blood pressure is high, then it will be RBC or whole blood that is
It
to be
is
transfused.
always RBC, never whole blood for anything. I know it's sitting in tertiary care hospitals or in big cities, it's very easy for us to say in periphery you may not have a blood bank in the next 20 kilometers, but I think such patient then you should transfer.
Comments on use of whole blood in case of shock patients.
So in a patient with shock, is because of massive bleeding. Yes, whole blood, but again, that's not whole blood. It's a reconstituted whole blood, 1:1:1 ratio. But just because the patient is in shock doesn't mean he needs whole blood. He needs volume expansion. So you give saline or you give colloid or you give albumin or you give whatever else and use the appropriate blood product. Like his hemoglobin is low, give him Paxil. If his platelets are low, give him platelets.
Well, how could we handle the iron load in thalassemia major cases?
Correct. So you do first ferritin at around 1.5 to 2 years of age, or when 15 transfusion are over. If it cross more than 1,000 and the child is more than 2 years, you start your chelation. So your two choices: either you can give oral deferriprone, that is Kelfer, or you can use Deferracerox. Deferracerox is single dose in a day, convenient to take and less toxic to the joints. Whereas Kelfer is 3 times a day, has to be taken orally, so it's only in capsule form, so a little bitter and can have some neutropenia and arthropathy. But otherwise, both are excellent. Remember, Kelfer is very good for removing iron from the tissue like myocardium. So patient with older child with myocardial dysfunction, Kelfer is better. But otherwise, you could use either of them. Sometimes you have to use both. Suppose the patient has come at 10 years, ferritin is 10,000. He has never taken proper chelation. You may have to use both. Now, the third drug, desferrixamine, injectable, is not available easily in our country. But when it is available, you can use that initially in a patient who has come in a failure or with severe iron overload or with organ dysfunction like diabetes, liver disorder, pancreas, or something like that. And so tide over the crisis by using desferrixamine along with Kelfer. And then once his ferritin is brought down, you can switch to only oral Kelfer or desferrixarox.
Well, we are coming towards the end of the chat box questions. If transfusion needed in a preterm neonate, is it required always to cross match with the maternal blood group?
Absolutely. Up to 4 months of age, the every blood product like Paxil should be cross-matched with both child and mother, because there are transplacental matter antibody from the mother in the child's body. So suppose the child is A and the mother is B. So child has NT-B because he is A and the mother is B, so she has NT-A. The child has both NT-A and NT-B. So you cannot take either A or B or AB. So you have to take only O positive blood. And if the mother is negative, then negative blood. So according to the blood group of the child and mother, you will come to the which is the most compatible blood.
So thank you, sir. Now I'll hand over the proceedings to Dr. Shapon Rai.
It was
After
an
this excellent
excellent
presentation and the question answer session.
was an excellent presentation, sir. We are really privileged to have you. And in fact, it will change our practice. It will change our practice because less than 7, less than 5, the children without knowing that it's due to iron deficiency, we will give one bag of the PRBC and then we will continue this iron. So
Correct.
we have our national treasurer, Dr. Atanu Bhadra. I can see his hand rising. So
Yes, he
over
has
to you,
raised hand.
Atanu, to give the vote of thanks. And sir, we are really overwhelmed and we are really privileged to have you in
Sir,
this
thank
meeting.
you.
So Atanu, over to you. Atanu, unmute yourself. Atanu, unmute yourself.
Excellent talk.
I think Atanu is not able to hear us.
We have relearned
No,
many
he has
things and learned
raised the
again.
hand.
Yeah,
He has raised the hand.
I know. I think he's probably not able to. Anyway, doesn't matter.
Okay.
So Mihir,
Thank
can
you.
you give
If
the vote
Atanu
of
is,
thanks?
yes,
Mihir, can you give the vote of thanks? I'm calling
yes,
Atanu.
Mihir. Mihir, you please
Unmute. Mihir,
unmute. Unmute, Mihir. Unmute yourself.
Aditya, unmute Mihir.
I think someone has
Aditya.
to ask, allow him to unmute.
Yeah.
I
So
think the host,
Aditya,
He is a
host has to
co-host. He
allow.
can do it.
No, he's not able to do. He has put I can't unmute. He's
No.
saying.
Aditya, please unmute Dr. Mihir Sarkar. I think he is not.
Who's the host? You are the host, Dr. Swapan, then you can do it.
No. I am not the host.
Okay.
Host is
Okay,
the
now
And
I
now
have
is-
got the yes.
Yes.
So yes, it is our honor and privilege to hear to have you, sir. So it is a very excellent and a very lucid presentation and very clear message to important to both for the peripheral pediatrician, even for the tertiary care pediatricians. It is applicable for all. So thank you for your knowledge and wisdom, as that will be very much helpful, and I think it will change our practice to all who with your guidance. So
Thank
again, thank you again, and all the members from the Central IAP who have joined today, and all the members of West Bengal Academy of Pediatrics. I think Atanuda has now, you can see
Yes,
him.
yes.
you can see him.
So, Atanuda, I
Atanu,
think.
please unmute.
Yeah. I was not being
Aditya.
allowed to unmute. Okay. Sir, I think thanks is a very small thing for you. We cannot thank you enough. Really, I had joined in spite of hard traveling, and I was not disappointed. You excelled yourself today, sir.
Thank you, sir. Thank you.
It
Thank
was
you.
such a spontaneous presentation, and answers came like bang on each of the questions.
Thank you.
What level of knowledge someone must have having to answer all these questions on the spot? It's really thank you, sir. Thank you.
Thank you.
Really, sir.
Thank you,
And
Atanu.
I
Thank
think I again think, which I have reiterated often, I think hematology should be your forte, not vaccine.
you. Very difficult for me to decide between the two.
Thank you, sir.
Good night, everybody. And
Thanks,
thanks, Dr. Nitin Shah, for with us. WAP is really
Namaskar,
indebted
namaskar.
to you.
Thank you,
Nitin ji,
sir.
namaskar. Finally,
Thank
good
you, sir.
night.
Thank you. Bye. Good night, everyone.
Bye.
Thank you.
Good
You.
night.
Night,
We
night, sir.
look forward to the next Pedicon.
Yes,
Yes,
sir.
definitely.
Okay, sir. Bye.
Okay. Bye.
Bye.
Bye.